Hello.
Hi.
Hi. Welcome, everyone, to the Curated Caregiver. This is our podcast for everything associated with what caregivers are going through, what they may potentially encounter, and things that they might even um, learn how to do better and navigate better through this caregiving journey. And I am Donna Jackson, the caregivers coach. And today I have with me Rasheeda Hall, MD. Our segment today is entitled The Dialysis Analysis, Nephrology and the Caregiver with Rasheeda Hall, MD. Welcome, Rasheeda.
Hi, Donna. Thank you for having me.
Thank you for being here. I know you are a super busy lady. And, as most of our podcasts come about, it's all during or after a great discussion in this space of caregiving for our elderly loved ones. And so, as your chosen field of study, you
hmm
are totally immersed in this with with the elderly.
hmm
And so, you know, can you talk about what kidney disease looks like in older adults and some of the really great things that we can know or we can get ahead of as caregivers for them.
Okay, yes, that's a very good question to start with. So, I'm a kidney doctor, and I particularly uh, have a clinic for older adults with kidney disease, and that is my research focus too. And so, kidney disease in older adults tends to look like part of a long list of other medical problems. Kidney disease comes with hypertension, it comes with diabetes, it comes with heart disease. And so that's one component where sometimes there's so many other issues that the kidney disease gets overlooked. Another component to highlight about kidney disease in older adults is that sometimes it's not so bad that we have to be terribly concerned, considering they have so many other problems. But yet, the absence of attention to it has that two sides. If we ignore it, it could get worse. And then some of our older adults, especially those who have many, many chronic conditions and have a need for help with their activities of daily living, it could be that kidney disease is not their main problem. It may not be something that will progress to dialysis. And sometimes that's one of the things I love to reassure to the caregivers where their loved one is now and how far they is from needing dialysis, which is often what worries everybody.
Yes. Yeah. I can imagine it. And a lot of times as our loved ones are aging or and even as we're aging, sometimes to your point, we think it's this slippery slope. We think that, things are just going to the natural progression of things is going to be downhill. And it doesn't have to be that way. Um,
Yes, yes.
thank you. Yeah, it's so interesting. So one of the things I want to ask you, how did you land in this space? How did you decide when you were in medical school, this is what you wanted to focus on?
Yes, it's a very interesting because me, like many other doctors, you like a lot of things. You may say you'll do this and then change your mind. So that was definitely the case for me. I did an internal medicine residency, which is often the gateway to all these specialties. So I then decided to do additional training just in kidney disease. The medical term is nephrology. However, before I entered nephrology fellowship, one of the things that stood out to me, which I think is still relevant today and to this conversation, is that people with kidney disease can have a primary care provider and a kidney doctor. And then there's confusion over who is doing what when it comes to that condition. And so I was really intrigued by that alone. Interestingly, that pushed me towards going into nephrology. And then it was during my training, rounding in the hospital, that the patients I had the most empathy for were the older patients, the ones who I saw kept coming in and out of the hospital. They're on dialysis, and I'm starting to wonder what's going on at home. And if they're in a nursing home, how well are they providing that dialysis diet that we think they need, right? And so that led me to start to ask more and more questions. And it just really became clear to me that there is so much to uncover, and also just a great need to figure out how to provide better care for them. And as I said, in and out of the hospital, that affects quality of life, that affects the caregivers. It's costly, right? So just really wanted to dig into a problem that hadn't really been studied well.
Wow. It's so interesting. I want to tell you that I was anticipating you were going to say that you had, an elder family member, or you had had an experience somehow in this field. But you know what? Even the fact that that wasn't your reasoning, Dr. Rasheeda, I'm telling you, this is what it looks like when you are being pointed in the direction of your purpose. That you're going down a path, and to your point, I'm thinking I like this. Maybe I'm doing something that I like or that I
Mhm.
want to do. And as you're on that path, you're being guided and directed into the true purpose as to why you're even on that path. So
Yes.
I mean, I heard everything else that you said, but I also heard that kind of underlying thread of purpose. I love it.
Yeah.
It's just so magnificent.
And I
To
want to interject because years after, and like in recent years, at least I think it was now almost 2 years ago, that I did have a personal experience. I had an aunt who was having kidney trouble and eventually started dialysis, and I was seeing the issues I just brought up to you playing out with her, and it was extremely frustrating to not be able to do anything about it, but also to give me, like, to your point, the purpose. It actually still motivated me and gave me opportunity to have that personal context to share when I do presentations and talk to my own patients.
Wow, so you hadn't actually plugged in fully here until your aunt's concerns came up. Is that what you're saying?
I wouldn't say not fully. I think it just has given me even more of a way to connect with the families and the patients, knowing than having that personal experience.
Yeah, but you were already on that path. Okay.
Right.
Oh, that is so wonderful. And I'm sure your aunt she feels that she's in such safe and competent hands with
Mm,
you, that if she can run things by you, you know, and that she's getting the best of care because she has another lens through which to bring things to you. I am That's so great to hear.
mm.
And so, by the way, how is she doing?
I didn't tell the rest of the story, but she is no longer with us. Yeah.
Oh my gosh. And I guess I actually should have asked you that. So I
No problem.
apologize for that. I'm sorry if that was triggering. You know, but the fact that you were able to be there for her
Mhm.
during those last days and months, that even that, I just want that to be super clear how powerful a testimony it was that you
Mhm.
could be there for her. And
Agree.
it's one of those things when I think about anyone
Mhm.
who is just living life and they are pursuing purpose, and how there are people waiting on us
Hmm.
to get there. There are people waiting on us And the sooner we show up as the person we were always intended to be, doing the thing we were sent here to do, the more people are going to be served by these gifts and talents that are on the inside of us,
I
right?
absolutely agree. Absolutely.
Yeah. Oh, I'm so sorry. I'm so, yeah. Yeah, I'm
As
so
you're saying it, and I'm thinking about that experience in particular, and I think that definitely relates to this discussion, and that is around um, accepting that there is decline, that health is declining. And I think for someone who is receiving dialysis and is going to the hemodialysis unit 3 times a week, and they come back home, and everyone may think things are about the same. I think it was the case for my aunt that we started to see things were changing, and very few people were willing to speak up and acknowledge that maybe we should be stopping dialysis. Um, and that was where understanding, like from my cousin, what was happening, I decided I think we should be talking about that. I don't know why these other doctors are not, but as much as we have faith, I'm seeing the objective signs. I'm seeing things are not getting better. And if she is suffering, then we need to consider stopping this treatment. And that is how the course went. And to be able to do that with family members, just hard enough. But I realized I was, like, to your point, being prepared. And I am often that doctor who comes in and tries to make sure the family knows what's really going on. Not trying to be Debbie Downer and having faith, but honestly, I think too often we, as doctors, hate to have those uncomfortable conversations, but I know the families, the caregivers really want to hear that.
man. And just thank you for that lens. And
Mhm.
thank you for this is ministry in a lot of ways, especially with when we do have that faith, that spiritual um, part of us that we want to express, that it is important to express. So your lens is so powerful because, to your point, there's so many doctors who they just keep the treatments going. And to your point, even the patients, the recipients, they have trust in that that medication, in that solution.
Mhm.
even. And they think,
Mhm.
oh my gosh, what are you trying to kill me? You're going to take me off of this? But you, with the lens that you have, are seeing that it's doing more harm than good. So thank you for that.
Yeah,
And it's
absolutely.
so courageous. It's really courageous for you to walk into those spaces and to actually give those messages. Wow. Mm.
Thank you. Mhm.
Yeah. How, in terms of, and so that our audience are mainly the caregivers of these very recipients of
Mhm.
medical care and treatment. Um, what would you say to the caregivers, and what would you like caregivers to know about kidney disease?
Yes, so to start, I acknowledge, like, everyone can Google and talk about and read about kidney disease. And if there was any website I would promote, it is the National Kidney Foundation, because I do think their information is valid, it's vetted by clinicians. So when it comes to chronic kidney disease, it comes in stages, the way they stage cancer. So the higher the stage, the worse the kidney disease is. Um, what I want caregivers to know in particular is you want to know where your loved one is when it comes to the stages. Most people in this country are stage 3. Plop
Mm.
down in the middle, that's usually around the time they're diagnosed, and a lot of them don't even have a kidney doctor.
Wow.
It can be managed by the primary care for sure. Stage 4 and 5 is when we're like, yeah, it might be useful to have a kidney doctor. Absolutely, stage 5. Stage 4 can be kind of in between, but this is where we might start to see the complications of kidney disease. And if someone seems like they would be a reasonable candidate for dialysis, and they're starting to do that kind of planning at stage 4. Stage 5 is that end stage. So that's why I think caregivers should know where their loved one stage is. I think also it's important to know, to get a sense for why they developed kidney disease to begin with. Now, the main reasons why someone would have kidney disease is because they already have diabetes and or hypertension. But there are some other conditions, some of which may be genetic. And I think if the caregiver is a relative, that sometimes the value of understanding a cause could mean more for the rest of the family too, especially if it's something that is heritable, and potentially there might be some specific medications for those types of causes of kidney disease.
Yeah.
I think there's definitely more. Would you like to talk about clinic visits or?
Yeah, absolutely. I mean, you're seeing this in real time. And, one of the things you said earlier was that you were seeing the seniors coming in and out of the hospital, coming back and forth in the hospital to the visits. And I wanted to ask you, were they alone? And did you see a part of what you do now as an advocate for them? Like, or are they coming with their caregiver? Or are they trying to navigate this by themselves?
Yes, yes. You know, there are different categories. So I would think about the individual who is in long-term care in a nursing home. They are not often with the caregiver. And maybe you might see that loved one come in periodically. But especially because that meant they were probably transported by an ambulance directly from the facility, then they're often by themselves. In other instances, absolutely, I think I'm more likely to see a caregiver in clinic than in the hospital. And I think that's because a clinic visit is brief, right? But if someone's in a hospital, I might have missed the caregiver, right? It might have been they had just left, or they can only come at a certain time because they're still working. So that part I think is harder to fully flesh out the reason behind. But I think the caregivers that I see in clinic are particularly, for the most part, are very interested in understanding things and knowing what they should be doing. And if I have someone who comes in without a caregiver, it is so much harder to do the visit in a lot of ways. And so I do think if that is the case, I'm more concerned for what they can do and the amount of assistance they have at home.
Mhm. How frequently do you encounter a caregiver who is willing and able, and the situation is is such that it can happen, that they're actually administering the dialysis at home for their loved one? Is that a thing now?
Yeah, there is a thing, and I'm happy you brought that up because that was one of the myths to dispel. Like, not all dialysis is going to the dialysis unit 3 times a week. There are some people who are doing dialysis at home, but it's so less common that it's not enough for the people, the community, to recognize that it is a thing. And so honestly, to part of how we have confidence in someone's ability to do home dialysis is that they have someone with them. Like that, they need to be trained and their caregiver needs to be
Yes.
trained, right?
Mhm.
And that allows that kind of backup if any acute time that there's a need for assistance, there can be someone else there to facilitate the treatment, to stop it, to help troubleshoot. Yeah.
Wow. Yeah, I just recently, a colleague of mine actually does that,
Mhm.
administers the dialysis for her brother. I mean, and she is a doting sister and
Mhm.
caregiver. And I had never heard of it before. So thank you for just letting the our listeners know that they can actually do this and get
Mhm.
some training,
Yes,
and
yes.
takes a lot of wear and tear also off, right?
Yeah, and I think so. Let's get into that. I think it's worth sharing and thinking about. I mean, it doesn't work for everyone, but the pros of doing dialysis at home would be absolutely cutting down that travel time. There's just no place like home in general, right? So you cannot replace that comfort. It also allows someone to do it on their own schedule, right? Um, so do they want to set up in the morning, especially if it's a hemodialysis machine, they might be able to stagger the time of day that they start. For peritoneal dialysis, that's a dialysis where there's a catheter going through from their stomach um, to a machine.
Mhm.
Most of those patients do it overnight. So that allows them to free up their day. Some of them might, if they're able to, are still working. So there's a lot more. It fits more with lifestyle is a nice way to put it.
Yes.
But on that, I think the things that might make it harder for this to work might be just someone's mindset. Like, is it too hard? Can I even do it? Right.
Mhm.
Um, but there's also some concerns, like we do home visits to make sure the home is sufficient. Is there enough space for the machine? Is it clean enough? So those types of things may also be barriers. Um, and then just in general, having the understanding and in a lot of ways there needs to be some attention to detail. You weigh yourself daily. You make sure you follow the instructions um, on a daily basis. So those types of things come into play. But yes, plenty of people can do it, can learn to do it, and we all should be open to it. Mhm.
Yeah. Wow. And the commitment, big commitment to doing that. Um, so, just in general, what are people generally getting wrong about kidney disease?
Yes, yes. I think one of the things I often hear a lot about from patients is, well, I don't feel bad. And so having chronic kidney disease, and this is before dialysis, right? Earlier stages, does not come with any particular symptoms. Like, you don't know if you have kidney disease unless you have the blood and the urine tests. For the most part, that is the case. If you have symptoms of kidney disease, then more than likely you are already stage 5. So I think that's
Oh,
one of
wow.
the major myths, is that you might think you feel something. You know, our kidneys sit in our lower back, but kidney pain does not mean your kidneys aren't working. It could be that you have a stone, maybe you have a kidney infection, which would come with a whole lot of other symptoms too. So that would be one. Another that I hear people talk about is thinking they just can drink a lot of water and that would keep any kidney problem away, which is not true. We don't have to overdo how much water we're drinking. So for the caregivers out there who are like forcing water on their loved ones, you don't have to do that. You just make sure that they drink if they're thirsty, right? Just drink enough, but not, you don't have to overdo
My
that.
God. I am so sorry that I'm chuckling here, but you know, it is so true. I am so glad we are having this conversation and debunking
Mhm.
just right in this little segment right here, these myths, because I remember, you know, when my sibling and I were caring for our mom, you know, I remember days we'd be like, Mom, do you want to go to the hospital or do you want to drink this water? Like, please just drink the water. Just drink the water. Like that's gonna solve everything if you just drink the water. So that I just gave you a flashback that we were, you just like just drink the water. That is so
I
interesting.
mean,
That
if the urine is not dark, they
yes.
probably have had enough to drink,
Okay.
right?
Yes. Yeah.
So yeah, don't for everyone out there, please don't overdo it.
Don't overdo
Because water is in everything, right? Water is in vegetables, it's in ice, it's in soup, right? So if they're otherwise eating pretty well, then yeah, we don't have to force more water.
yes. Oh wow. Yeah. So good. So let's go back to a kind of a general scenario and question.
Mhm,
So as our loved ones age, and just like we go from a pediatrician to a general practitioner, general
mhm,
practice doctor, at what time and at what age maybe should we as caregivers consider either going to a gerontologist or someone who is really specializing in the elderly and the care of the elderly? Is it necessary?
mhm. Yeah, this is a very, very good question. And I think that some doctors who are not trained as geriatricians can do very well caring for older adults. In fact, a lot of people who train in family medicine are trained across all age groups, right?
Mhm.
They can do kids, they can deliver babies, they have all of that. I did internal medicine, and I think one thing's for sure is that the population is older. So we see older patients all the time.
Okay.
However, the emphasis on the geriatric problems or how to not be ages um,
Yeah.
is not as it doesn't permeate the curriculum as well as it could for all clinicians. But to answer your question, I think the win um, is usually in the face of geriatric problems and probably more than one. Um, so, when I say geriatric problems, I'm referring to problems that tend to be more common in older adults. That would be someone who's having falls, who's having trouble walking, whether they're feeling unsteady or their gait is slow. Um, People who might have trouble with thinking. We do recognize that there are issues with memory as we get older, and that's not necessarily alone a problem. But if there's trouble with thinking that your loved one is having, they recognize and it's bothersome to them, and you can tell that it's limiting their ability to do things like manage their medications or like do their checkbook or some of the things that they could do and now it seems strange. Like that is concerning.
Mhm.
And then also there are things like incontinence that might also be a reason or geriatric problem to consider. I'm sure there's probably a few more. There's one umbrella term called frailty. Um, it's a syndrome, but it's not very specific to one organ. So it's hard to describe on a podcast, but essentially it's kind of a way of describing someone who's particularly vulnerable, maybe in and out of hospital a lot and having a lot of weakness. Um, but so I would say, like, if there's an older adult who may have maybe just one of those problems, it may not be a huge trigger to go get a geriatrician. But I think if there are multiple problems, uh, that is more concerning.
Mhm.
Um, and I think because there is a shortage of geriatric providers, um, that there's a huge push from their perspective to make sure all doctors know how to manage older adults,
Mhm.
so that they can manage the ones who have multiple problems of aging,
Mhm.
and let the rest of us manage the ones that are not as severe.
Yeah, very interesting. Very interesting. So what, and as you mentioned, the population is aging.
Mm.
And so how does this look for a person who has been generally in good health all of their lives, but because of maybe some inherited condition, they have been on a medication, maybe not like a heavy dose, but consistently for decades, right? So I'm thinking of high blood pressure medication, not, maybe even low doses, but still that it's something that they have to have for many, many years.
Mm-hmm.
So, but other outside of that type of thing, generally healthy. How does that kind of a consistent medicine in your system impact your kidneys as we get older? And is there something that we can do?
Okay. Yes. Yes. You know, the kidneys are organs that help with clearance of medications, but not all medications. It's like the kidneys and the liver. And even though that is the case, if your kidneys are working well, then you should be able to clear the medication, not have any problems with it accumulating in your body. Okay. But to your point, if you've been taking a medication for years, if it is not a medication that is known to harm the kidneys, then you're good. But I'll point out some that could harm the kidneys because I am a kidney doctor, and the PSA about things like ibuprofen. So those non-steroidal anti-inflammatory drugs that you can buy over the counter. If you started taking ibuprofen almost every day in your 20s and 30s and you're consistently taking it, it is causing some chronic damage to your kidneys. Okay. And so that is part of what we do in an initial consultation. All the different questions we're asking, we will ask about medications because medications can harm kidneys. And it's not just, so I named something over the counter, which I think is important because there are a lot of those over the counter medications, even dietary or herbal supplements that are not regulated, but can potentially harm the kidneys, that we're starting to kind of be mindful of and ask our patients about. But generally, they're just thinking about the whole spectrum of medications. I would say that if you were prescribed something earlier in life and your doctor knew there was a risk of harm to the kidneys, they should be monitoring your kidney function over all those years, right? Because there are certain medications that you absolutely need for your condition. So, for example, my father has a heart transplant. He is taking an immunosuppressant to prevent his body from rejecting the heart, but that medication is affecting his kidney function. So they are monitoring that. So that's my point. It's like under good medical care, it shouldn't be a worry.
Okay, that's really good information. So you mentioned earlier that if you actually start feeling stuff happening with the kidneys, it's probably really advanced at this point because you wouldn't normally, even if things are happening at the 1, 2, and 3, you're probably not going to feel anything.
Not feeling anything, but
yeah. And so with if we have just regular insurance, could you go to your doctor and say, hey, I want to get a kidney test? And would the insurance pay for it if you're not an elderly person?
That's a good question because I do not think, well, I think there has been ongoing efforts about screening for kidney disease.
Okay.
It has not been something that is recommended for the general population. I do think if there's a risk factor, like if you have high blood pressure, you have diabetes, older age, I think those are things for sure that would not be an issue with coverage. I would imagine there's something else, but I think one could even consider anything metabolic like obesity, because that can be a risk factor too. And then, so yeah, I think I've answered your question there.
Yeah, no, that's great. That, I mean, yeah, it was kind of not what I wanted to hear because I'm like, all right, well, let's get ahead of this, like get in front of it, right? But I think what you answered is probably for most things, you know, because I've had like some pain or something. I'm like, I want an MRI. The doctor's like, yeah, no, I'm not giving you an MRI. I'm like, come on, man. I want to make sure I'm okay. It's like,
Yeah.
oh, you have no signs. There's nothing indicating that anything's wrong with you. So that's why I asked the question. So
Yeah, but I want to back up and to be clear about this is that when someone does have an annual exam and doing like annual physical and workup and blood is drawn, they will be testing your kidney function.
oh, that's
Okay.
right.
Okay.
Yes.
You're getting that creatinine, you get the GFR. So it is happening. You would not need any extra rationale. Okay.
So good. That's right. Thank you for that reminder. That is right. Oh, man. Okay. Man, you are giving out such great information to a community of people who sometimes don't know what to ask. And that's why we're here. And that's why, I try to bring experts such as yourself into a space specifically for that caregiver. They're
Mhm.
trying to manage so many things, keeping themselves together and healthy so that they can provide the levels of care for their loved ones, their elderly loved ones. And you have
Yeah.
just shared so much so far. I have a couple more questions that I hope we can get through.
Yes.
Um, with everything that you shared, is there one, two, three things that you would suggest that the elderly and their caregivers do at a visit? Something we might not have talked about yet.
Yes. Yes. Um, I don't think we've talked about this. I know we've talked about how diabetes and hypertension are some of the main contributors to kidney disease.
Mhm.
Often, someone who already has kidney disease is is having trouble with keeping their blood pressure at the target. So our goal in general is under 130/80. Um, However, for some of our older patients, someone who might be in their 70s or 80s, at least myself personally, I will be willing to be more liberal and let that top number be right as high as the 140s or 150s. Still, I like to see blood pressure readings. I would love when my patients bring in their list that they have a cuff at home, they're checking it every day, because I can make more sound decisions on what to do about their medications when I see more numbers than the one in front of me in the clinic. We do see that sometimes there's that anxiety, that what we call the white coat hypertension. So the blood pressure may be higher, or just that morning they rushed in,
That's
they
right.
had trouble parking, they're stressed already. So I think bringing those readings, bringing the medication bottles too is extremely helpful. And I think it's just so important that you ask clarifying questions.
Mm.
Now, I recognize that a caregiver may don't want to ask a dumb question.
Yeah.
There's, especially if there's not race concordance. So you have a white doctor, you might be feeling some kind of way. You may not trust him, or either you just don't want to show that you don't know something. Whatever the case, I'm saying throw that out the door.
Yeah.
Get all the information you need to feel comfortable leaving that office and continuing to care for your loved one.
Yeah.
I think I get a lot of questions. I think that my patients and their caregivers just they know I'll answer them, and they feel comfortable asking me questions. And so sometimes that part of the visit can be one of the longest parts, because they're just like, what about this? So I think that was my 1, 2, or 3. Bring your med bottles, bring your blood pressure, and ask.
I love that so much because you're so super approachable. You put people at ease. And to your point, that race discord, people are intimidated. And you're so right. They don't want to seem ignorant. And we're ignorant. We're not doctors.
No.
And yeah, but I can just see how that shows up in people. They just don't want to come off that way, or even in front of their loved one, so that their loved one's like, oh my gosh, you don't know what you're doing. So
Yeah.
I can see all of that struggle there. Man, this is so helpful. All right, I'm gonna combine a question here, and then we'll go into our final kind of question. So you have kind of laid out just beautifully what dialysis does. Tell us a couple of things that it doesn't do, and what might be some alternatives to dialysis.
Okay. So dialysis refers to this process of your blood being quote unquote cleaned. So in kidney disease, once someone has kidney failure, the toxins that your body usually removes with your urine tend to accumulate in your body. And so it is this process of removing toxins from the blood and returning the blood to the body. And so with that, it also not only is toxins, it has to do with electrolytes, just trying to remove things that your kidneys otherwise couldn't remove. And that's essentially it.
Mm-hmm.
However, I think one of the things to point out is that a typical dialysis treatment, if it's hemodialysis, is like 3 to 4 hours a day, but only 3 days a week. But remember, we have 24 hours a day, 7 days a week, which means that it can only do so much, right?
Mm-hmm.
The toxins will come back. The imbalance in electrolytes do come back in between treatments. And that's why it's set up to be recurrent, but also that's also why kidney doctors like myself say that the best way to help someone who has kidney failure is to get them a transplant, because now they have a kidney that works 24/7, not just the periodic 3 days a week. And now I recognize that our audience, and we're talking about elders, and there are some older adults who can get transplant, but I think they do have more barriers to transplant. So I recognize that may not be for everyone, but I think it's at least worth inquiring if it is a possibility and what that path looks like. Regarding other myths, I think some people think that dialysis is the only option when you have kidney failure. And so I think for the sake of time, that would be my another myth to dispel, is that when someone enters that stage 5 of kidney disease, and our approach with their options, and so the options would be are often just dialysis is presented to older adults because some people may not think they'll be a candidate for transplant. But I think another option that we are not talking about enough is something called conservative kidney management. What that means is you do not do dialysis. However, you have a kidney doctor who is monitoring you and managing any complications related to your kidney disease just with medications. And so like this week, I talked to one of my patients who I've been following conservatively, like at least 2 or 3 years now. We do visits every 2 to 3 months. She goes in for labs. I ask her about her symptoms. I tweak medicines where I need to, but otherwise she would be on dialysis. Her labs are that bad, or at least, to the kidney community, that they were like someone who would see her chart would assume that maybe she's on dialysis based on the labs, but she is not. So I do want caregivers to know that this is an option, and is often a really good option for someone who's already having some disabilities, because being able to go to a dialysis unit requires you to be able to walk and sit in a chair. There's a lot. It's not set up for older people who have a lot of disability, and so conservative management, it's just really much better for quality of life. It's kind of like similar to the home dialysis in a sense. There's nothing keeping you from how you want to spend your day in that sense. And caregivers are really, really helpful for those people who choose conservative management, because they can keep an eye on the medications and on any symptoms that are changing, and alert me or their kidney doctor about that.
Man, Dr. Rasheeda, I could talk to you all day about this. And I'm just telling you, we are definitely going to bring you back.
I love
At
to.
some point.
Absolutely.
It's just so rich. It's so much really good information, just organic information. It's not anything heady that anybody can't wrap their head around and actually implement some of the things you've suggested.
Mhm.
I have one serious, this is the serious last question before
Okay.
we close out. So, are you saying that a simple change in diet is not enough to fix what's going on with the kidneys? And I know you can keep it like just simple. I know it might not be yes or no, but I was just thinking,
Okay, yes, the nuance. I my brain is going to nuance. Not for everyone. I
okay,
think that a change in your diet can help prevent kidney disease. But
okay,
once you have kidney disease, it may not be enough to keep things from getting worse.
all right. And we're gonna leave it there because I know. Listen, y'all, Dr. She is busy. She has some deadlines she has to meet today. But listen, Dr. Rasheeda has started a clinic, you all, and for our elderly, specifically those dealing with kidney disease. So we're going to bring her back to tell us why she started it. But if you can do it quickly, we'd love to hear it now, and why it is different from other clinics.
Absolutely. So right now I practice at the VA here in Durham, North Carolina, and so it really was born out of my research interest and noticing that there was a gap in how we provide care. So my clinic in particular is one where I assess for these problems like falls and cognitive trouble, and or thinking problems, and as well as someone's ability to walk, um, and I also try to uncover what matters most to them. We call that the geriatric M's: mobility, mind, medications, what matters most, um, and multi-complexity. But I also like to manage those people who choose not to do dialysis. So in my clinic, I make time to talk about it, explain to them what it's about, explain to them um, all their options. And so I do follow many people who have chosen not to do dialysis, as I described that conservative management. So it's been
That's
fun.
it has been. So you all, we're going to bring Dr. Sheeta back because she is doing some world changing research in this space. And we want her to come back and share it with us. She's on the cutting edge, the breaking edge of new science, technology, everything in this space. And we'd love her to share it with us.
That would be
So,
great.
you all, I hope you have enjoyed this. This has been the dialysis analysis, nephrology and the caregiver with Dr. Rasheeda Hall, MD. Rasheeda, thank you so much. We look forward to having you back.
Thank you. This was fun. Thank you for having me.
You're welcome.